Okay. Hello. Uh, my name is Dr. Ben Greenberg. I'm here with Dr. Maria Mancebo, and we are delighted to be talking to you about the intersections between OCD and PTSD and, to some extent, OC personality disorder. I'm a professor of psychiatry at Brown University, and I work at Butler Hospital as well as the VA. And tonight I'll be talking mostly about things that are relevant to my VA experience treating veterans. Dr. Mancebo is going to tell you about what she does.
So I'm a clinical psychologist and I specialize in cognitive behavior therapy for OCD. And so I'm going to sort of share, I'm a clinical associate professor at Brown, and I've worked at Butler Hospital for many years, and I'm now in private practice. Um, so I'm going to talk a little bit about my experience in providing psychotherapy for people who have OCD and who have histories of trauma.
Okay, and so I think we're going to start with Dr. Mancebo, and she's going to start from the OCD perspective, which to most of you, given that this is an OCD Rhode Island hosted event, may be more familiar. And then I'm going to go on and talk about the experience of diagnosing and trying to treat OC phenomena in a PTSD clinic where I work at the VA. I'll also address issues of medications and other kinds of treatments for OCD as well as PTSD. Dr. Mancebo, take it away.
Sure. So I think for this audience, we all know what OCD is. In our clinics and in my practice, primarily people are coming in for these intrusive thoughts and compulsions and rituals that they are engaging in. And sometimes they do have a history of trauma and they may have PTSD symptoms. So, one of the things that I would like to sort of start with is like what the evidence-based psychological treatments for OCD are, and how that might overlap with someone who has both OCD and PTSD symptoms. So if someone's coming in with primarily OCD symptoms, we always start with a discussion of exposure and response prevention, because that is still the behavioral treatment that has the most solid evidence base for treating OCD. Um, and PTSD, there are currently two psychological treatments with a very strong evidence base for being effective in reducing PTSD symptoms. One of them is prolonged exposure. And with prolonged exposure, what we do is we try to teach people to gradually approach their trauma related memories. And any feelings that they might experience when they're reminded of their trauma and any situations that are associated with these past traumatic evidence. The goal in PE, or prolonged exposure, is to help people learn that these trauma related memories and cues are not dangerous in themselves, and that they don't need to avoid thinking about them or keep trying to push them out of their mind, because that actually has the opposite effect, where they may experience them more vividly and intensively. So that's very similar to what we do with OCD, where we're trying to teach people that their intrusive thoughts are not something that um, it's not something that's important for them to engage in or experience. So we try to help people face these thoughts and these memories so that they can let them go and let them pass. Um, Prolonged exposure, one of the differences is that sometimes you need longer sessions than you do with exposure and response prevention. Typically, if someone has a very severe PTSD symptomatology, we need about 60 to 90 minutes just to be able to activate these trauma-related memories and experiences and to process and have enough time to process the experience. So both treatments for OCD and PTSD, you can do these exposures in your imagination, imaginal exposure, or in vivo. And it's still the same process where it's a gradual exposure. We make sure that the patient has some say in what they're doing and how quickly they go through these exposures. And the patient really sets the timeline for going through the exposure. Sometimes we also, with imaginal exposure, one of the differences is with PTSD, we help the person describe the memory in detail in the present tense and help them process the emotions that are raised by that imaginal exposure. And then we'll usually record the patient describing that event so that he or she can repeat the exposure in between sessions. So this is kind of similar to what we do with imaginal exposures for OCD. And then in vivo exposures, we help people gradually confront situations or places or people that remind them of the event. So again, pretty similar to OCD symptoms where that people may be afraid of triggering their intrusive thoughts and may either use compulsions or avoidance behaviors to try to prevent that. So we help people and encourage people to gradually confront these situations and reduce their avoidance behaviors. One of the other treatment that is has a solid evidence base for PTSD is cognitive processing therapy. And that's a type of psychotherapy that focuses on the thoughts or beliefs that contribute to PTSD symptoms. And in this kind of treatment, we help people learn to identify, modify, and challenge unhelpful beliefs about the trauma. And it starts with identifying automatic thoughts that may be maintaining PTSD symptoms. And then we help people process the trauma in a different way. The person may write down a detailed narrative of their worst traumatic experience. And then we might have them read it in session to try and break that pattern of avoiding thoughts and feelings associated with the trauma. And then we try to help people question their unhelpful thoughts about the trauma, and we call that challenging their beliefs. So a very common one is that the traumatic event was their fault. And so we help people really sit back and think, like, was it really their fault? Could they really have prevented this horrible thing from happening? And we do that to try to modify their unhelpful thinking. So when someone has both OCD and PTSD, one of the first things we try to figure out when we're building their treatment plan is whether their OCD symptoms overlap with their PTSD symptoms. So for example, if someone has a history of a violent trauma and they have OCD symptoms where they're afraid that they might have made a mistake and left the door unlocked, and someone might break in. Those kinds of symptoms are usually overlap, and so it's very difficult to treat the OCD symptoms and have people give up their rituals of excessively checking to make sure that things are locked, without addressing the traumatic memories that they have and the beliefs about the trauma, and their trauma related memories. So we can do both through exposure, and response prevention. We give them space and time to process their any traumatic memories that come up during those exposures. And then sometimes someone will have OCD and PTSD, and their symptoms do not appear to overlap. They seem like they have trauma-related memories, they have avoidance behaviors related to the trauma, but then they have these OCD intrusive memories that don't seem to overlap, and they have compulsions that are tied to those intrusive thoughts. And so then the way we might proceed in therapy is we have a couple of options. We can just create an exposure list that sort of meets their goals. I like to sort of start with, like, what do they want to address first, and start with general goals, and then proceed with our treatment in that way. And so it may be that their OCD symptoms are causing them the most impairment or the most distress, and we start with some exposure and response prevention and treat OCD, or vice versa. It could be that they really want to work on their PTSD symptoms first, and once we do that, we may work on the OCD as well. Oh, are you muted, Ben?
I was muted. I'm unmuted. Let me ask you a couple of questions, Dr. Mancebo, if I might. Do you think, I want to address the concept of moral injury in PTSD, where people feel that actions they took in the past or did not take associated with a traumatic event violated their moral code. And do you think this could overlap scrupulosity in OCD?
Absolutely. And it also could overlap with the taboo thoughts, where there are beliefs that they may lose control, and they may, do things that violate their moral code, even if it was unintentional. And so I think it could overlap.
When would you refer somebody to a more intensive treatment setting for either diagnosis, either an intensive outpatient program or a bona fide residential treatment setting?
So it depends on the program. There are some programs that are able to target both. For example, a group-based program like the one at Butler, it's usually geared towards OCD, and so if there isn't a lot of access to individual therapy, it could be difficult to process the trauma in a group setting. And so that would be a consideration just in the type of program that you would refer somebody to. Many of the residential programs do have a lot of access, provide treatment for OCD. And as long as the person's PTSD symptoms are stable enough, like if they have symptoms like dissociation, that could present a problem in an intensive setting.
You want to define dissociation for the viewers?
Sure. So that's when, somebody is triggered and experiences a trauma related memory, and then it almost blacks out for a period of time where they're unable to process what is happening in that moment. And they may feel like they're um, re experiencing it, and they just are, it's an out of body sort of experience. Um, and if someone is dissociating, obviously they can't process what is happening during the exposure. So we need to take a different approach.
For the viewers again, how can somebody tell? They're going to a clinician, primarily a therapist here. How can they tell if they're getting therapy that is, let's say they don't have PTSD, they have OCD. How can they tell if they're getting therapy that is specific for OCD, as opposed to sort of trauma-informed therapy that is kind of common out there these days?
Well, I'm not sure what you mean by trauma informed
Well,
therapy.
people are trying to address the trauma as the cause of the OCD.
Okay. So, one very, again, I'm an OCD therapist that sees clients who have not done well in previous therapies. So, I don't see people who might benefit from things, trauma informed therapies. But one that's very popular is EMDR, eye movement desensitization and reprocessing. And sometimes there, the intent is to help people process a trauma. But if that exposure is not done a in an informed way, people actually feel worse afterwards, and they continue to get worse because you're not targeting. So it, if someone just has OCD and has a history of trauma, and the therapist only focuses on the trauma because they believe that is causing the OCD symptoms, I tend to see people get worse over time because they're not addressing the OCD. And there's that false assumption that what's causing the OCD is the trauma. And I think most of the evidence out there says that people who experience trauma, trauma plays a role in the onset of OCD. It may sort of bring it out or maintain some OCD symptoms, but so do many other things and other stressful life events and even stages, developmental stages. So it can actually harm people to reinforce the belief that if they had not experienced that trauma, they would not have developed OCD.
Okay. In your experience and in the literature, if someone is presenting for treatment, they're seeking treatment for OCD, how common is it for them to have fully diagnosable PTSD?
I think, and you can correct me, that the rates are about 20 to 40%.
Other way around. In an OCD group, the rate of lifetime PTSD is 8%. And that means at any given time, probably the number of people who have diagnosable PTSD might be less than 8%.
Right. That's from our longitudinal.
That's from your paper.
Yeah,
and
right.
I'll talk about the other way around. People going to a PTSD clinic and how often do they have OCD? And I might start doing that right now. So let me do that. So like I said at the beginning, I have now a number of years of experience after having been an OCD specialist for many years, and still am. It didn't go away. I did not grow it. Working in a PTSD clinic at the VA here in Providence, I have been quite struck by the prevalence of OCD symptoms and OCD, and also OC personality. And those are a little bit different, though they overlap. We'll talk about that. In the people who come for treatment in a PTSD clinic. Now, I don't do psychotherapy except usually sort of supportive or something that could be called present-centered psychotherapy, which actually is effective in PTSD. But I see patients, and they're mostly coming to me for medications. They may ask about other kinds of medical treatments, like transcranial magnetic stimulation, or rarely neurosurgery for OCD now. But for PTSD, there is treatment that overlaps, just like Dr. Mancebo said. The main treatment modality is antidepressants, that serotonin reuptake inhibiting antidepressants that are used in OCD. So as exposure as a therapeutic maneuver is similar, although not identical, across OCD and PTSD, so are medicines largely overlapping, although not totally. And there's one trick that is worth paying attention to, which is that often, if someone has significant OCD symptoms, they need higher doses of the serotonin reuptake inhibiting antidepressants than might normally be used in PTSD or depression. And it's worth noting that depression is the most common co-occurring diagnosis in both OCD and PTSD. So we're really talking about people who have overlaps of multiple diagnoses. And of course, the more you have, the more difficult treatment might be, and the more impaired someone might be. It's certainly the case that if somebody with OCD also has PTSD, their course and their treatment may be more challenging, and vice versa. But some of that may be because the recognition isn't there that they have both kinds of conditions. So you heard that if you take a group of people coming for treatment for OCD, they're over a lifetime, they've got PTSD at a rate of something like 8%. It's much higher in a group of PTSD, people coming for treatment for PTSD. They have OCD at a rate of 20 to 40%. Up to almost half of them. And that leaves aside people who might have a compulsive personality in addition. And so it's critically important to recognize this. And because there is so much more emphasis, frankly, both in the popular culture and clinically in PTSD than OCD, and that's not just in the VA system, but it's particularly true of the VA system, that really recognizing this is critically important. So Dr. Mancebo talked a little bit about how you might distinguish the symptoms and how they might co-occur. I want to just touch on some of those issues again. So an intrusive thought of PTSD, of something horrible happening, by definition, it's something that actually has happened, that is recalled later in life. And an intrusive thought of something terrible that might happen in someone who has OCD can be identical. The thoughts can be identical, except that in one case, one has actually happened, and another, it's an imagined thing that has not happened, that is feared and can cause avoidance, tremendous distress, and impairment. And you get these overlapping symptoms. It is important to do clinically, and for some of you viewers, you can actually do some checklists and take a look at what kind of symptomatology people may have. So for example, let me show a quick, very brief screening for PTSD symptoms to talk a little bit about them. So here is a 4-item screening test called the short form of the PCL5, and that's a checklist for PTSD or DSM-5, a diagnostic system we use. And these 4 items cover important features of PTSD, not quite all of them, but important features of PTSD, re-experiencing a traumatic event, which, as Dr. Mancebo told you, could, in severer cases, result in dissociation, the idea that someone is disconnected from their actual environment while they're having a re-experiencing event. And then avoidance of situations that remind you of the trauma, for example, driving on certain kinds of roads or trying to go somewhere on July 4th where you don't hear fireworks. There are tremendous examples of avoidance, feeling cut off from other people, and irritability and anger. And that one is something that I want to focus on because that can be particularly problematic clinically and in interactions with other people in their lives, at work, all sorts of things. All sorts of bad outcomes can happen as a result of that. And although I haven't talked much about the OC personality yet, I'm going to right now. And OC personality is a condition that can overlap with OCD, that is marked by interpersonal rigidity and a sense that things have to be done right. And here is a scale developed by one of our colleagues, Anthony Pinto, called the POPS, which stands for the Pathological Obsessive Compulsive Personality Scale. And I just want to bring this up. There are multiple screening tests of this type out there, but somebody who is highly detail-oriented, they can't delegate things to others, they can't express emotions easily. But number 4 is one of these features that if somebody has this, they can have a lot of anger outbursts and potentially wind up in an anger management clinic, or at least that would be a focus of clinical care. And if it's all attributed to trauma, as Dr. Mancebo said, the treatment may not be correct. Okay, and look at item 13. I punish those who deserve this. Or 21. Other people say I'm argumentative. You can see how these things may create problems. And I'm not going to say a ton more about OCPD, but that it's always worth thinking about whether somebody might have this if they have a diagnosis of PTSD or anything else, depression, OCD, and an issue that keeps coming up is interpersonal conflict when someone feels that things are done wrong, they're not following their rules, or they feel that their boundaries, or the way they have to do things has been violated. You can see this in OCD too, especially the kind of OCD that is characterized by what we call incompleteness. Okay, I'll stop doing that now.
And I just want to say, I think that's so important, Dr. Greenberg, because a lot of the anger comes from their high expectations sometimes. And so if someone crosses them and they're unable, so for example, road rage, right? If someone crosses them because now they're unable to drive the way that they think they should drive or get to where they need to be the way they should. And so we talk a lot in therapy about these should statements and how it really underlies a lot of the anger that people with OCD personality experience.
Absolutely. That has been called the tyranny of the shoulds sometimes. So I think that, the idea here is to give you a sense of some of the things you should be paying attention to. If you or a loved one or a friend is presenting for treatment or might present for treatment for one of these conditions, note that they commonly co-occur, more so if PTSD seems to be the presenting problem. More of those people seem to have OCD or OCPD, at least in the ways we've been discussing, than the other way around, but they co-occur in both directions. And I want to talk about road rage because we really see this a ton in the PTSD clinic. That is one where there really can be an interaction between people's being sensitized by a traumatic experience while driving, let's say in a theater of war, and people are not doing what they should be doing, and there's a terrible outcome. Plus, people getting angry when people don't follow the rules of the road, and both may co-occur, but sometimes it's more one than the other, and it's important to figure out what is what. Again, for this audience in OCD Rhode Island, I don't know that we need to go over, how you screen for OCD symptoms, but I'm going to do it anyway. This is called the STOP, or the screening test for OCD. You can download this from the web, from the NIMH, National Institute of Mental Health website. And this just gives an example of OCD symptoms. And I give something like this to every patient I see in PTSD clinic, along with the POP scale. And true to what's in the literature out there, about a third of the patients, I would say, have something like this. It's really quite amazing. And it is often, it's never been diagnosed. It's never been paid attention to. The psychotherapy has not been targeted at this. And the medication doses and the medication combinations you might use, when you get to combinations, they could be different for PTSD and OCD and for comorbid depression. And so although there are some medications that where use is relatively discouraged in PTSD, that is not necessarily the case. In fact, it's absolutely not the case for OCD or, in many cases, depression. I think that if you're going to take home anything from this presentation, what you ought to take home is these things co-occur. You've got to pay attention to both. And you have to pay attention both in how you think about what's troubling you or a loved one, and how you think about what may have caused it. And let's talk a little bit about the fact that OCD runs in families, and it can be heritable, we believe, and we think there's a significant genetic component. There's a lot of studies that have shown this, and we also think there's a genetic vulnerability to PTSD. Remember that most people who get a severe trauma don't get PTSD. They have an acute reaction, that's for sure, but they don't develop months or years of the kinds of symptoms we were talking about earlier. And yet there does seem to be vulnerability that can be at least partly, I don't want to overplay this, but partly genetic. And so one thing you want to think about if you're trying to figure out where this came from, where these symptoms came from, is what runs in families. And that is often given short shrift clinically. And not in all cases, but if you're presenting for an initial evaluation, which sometimes happens over several sessions, in an outpatient office, is reassuring, or ought to be reassuring for someone as as the identified patient. If someone goes into the family history, has anybody been treated for any psychiatric problem? And what about any obsessions and compulsions, like things on the list I just showed? What about a very rigid interpersonal style and getting really angry if your rules were violated? What about those in first-degree relatives, especially parents, but not only? And those things are really important in helping people understand where some of their difficulties may have, at least in part, come from. And it can help take guilt away from some people. They can, somewhat, that it's not because of something they did or failed to do in their past. So I don't have much else to say here. I asked Dr. Mancebo a lot of questions, so in revenge, she may ask me some. I don't know. Got it. Okay, all right. Let's have them.
But as you were talking, I was wondering what you think about TMS as a treatment
Yes.
for people with OCD and PTSD.
Okay, fair question. TMS, transcranial magnetic stimulation, is an FDA-approved treatment for major depression, for OCD now, and even for smoking cessation. And it may be approved in the near future for PTSD. There is a particular kind of TMS that is approved for OCD that really focuses on stimulating the middle part of the brain. And so how this works is you have a machine that's a pretty powerful electromagnet that switches on and off. You're sitting in a chair, you're awake, and the device puts a magnetic field through a device that's a coil on the top of your head. For OCD, there are a number of different designs, but they all are electromagnets. The approved kind of TMS for OCD involves provoking symptoms. The idea here is that you want to interfere with the brain processing that is responsible for the underlying OCD symptoms. So that's the method that usually works. And ideally, you should be working with someone who's quite experienced, probably ideally a psychologist, to work out the symptom provocation method that is then not done by a psychologist every time. It's done by usually the technician or other staff delivering the treatment. And it is delivered daily for weeks. So you need to come in every day for weeks. It does seem to work. In other words, active stimulation is better than sham, where it looks like you're getting stimulated and might sound like it, but you don't. It really needs some improvement, but it does work for some people who are resisting other treatments, and is worth considering. And I say this as actually the person who did the first TMS study ever in OCD quite some time ago. So it's worth a try if it's accessible to you. It can be expensive, and it's not always covered by insurance. In TMS for PTSD is delivered primarily either off-label. Again, you're not going to be getting insurance to pay for this, but a lot of people with depression who also have PTSD might get TMS for depression, which may also help to treat the PTSD, just as treating depression often helps OCD. But there's more variety in the methods of treating PTSD with TMS And a lot of this is in the VA hospital system because insurance coverage doesn't matter so much in that system. So there are TMS clinics in a lot of VAs around the country, and they use this, and the results in open label use are actually pretty good. And different methods of TMS seem to work comparably well, although we don't really know that, but on an initial look, that seems to be the case. So, but they're different from the approach for OCD. And so, as we have been saying, it's really important to identify what the thing you're treating first is. How's that?
That makes sense. And if someone was presenting at a TMS clinic, because I think there's a lot of them now, like they seem to be.
There are hundreds and hundreds.
How do they know if the TMS treatments that they're getting, like they can go in and for a medication evaluation, and the psychiatrist will prescribe sertraline, and they can see that that's an approved medication for OCD. How do they know that the TMS targets, right, are the right ones for OCD versus depression? Are they different?
Yeah, they are different. They are different. My advice there would be to actually, I don't always tell people to go to the internet, but you go to the website of the manufacturer of the device that is being used, and there will be pictures of somebody getting TMS for OCD versus somebody getting TMS for depression. And normally what you see in TMS for depression is the magnetic coil is put on the left side, the left dorsolateral prefrontal cortex. And for OCD, it's in the middle, or there's actually a whole helmet that is designed to maximally stimulate the top middle of the brain. And they're different. And the other thing is that, at least for the approved treatments, there are other things that are done in research, that for OCD, there should be a thought out process for provoking symptoms while somebody is getting the stimulation. And that does not happen for depression.
That's helpful.
Okay, great. I think we've made the main points we want to make tonight. And I'm hopeful this has been helpful to our audience. And I've really enjoyed working with Dr. Mancebo here, due to the miracle of Zoom technology, which we're really familiar with at this point in our lives. Hopefully this is helpful to the OCD-RI community.
And we will take questions through email, right?
Right. I think, they'll, you would email the OCD-RI and they'd come to us.
Yep.
All right.
All right. Thank you, Dr. Greenberg.
And thank you, Dr. Mancebo, and good night, everybody.